Good morning. My name is Dr. Jeannie Kaneshiro, and I'm a breast surgeon at the Peter Lougheed Center, which is a hospital just around the corner here from Agate Laboratories. And I'd sincerely like to thank the Agate Foundation for the opportunity to share with you today something that's very close to my heart, which is advancing new technology in breast cancer surgery care. To give you a bit of an overview of how breast cancer affects women in Canada, the statistic currently is 1 in 8 women in Canada will be diagnosed with breast cancer in their lifetime. In fact, everybody knows someone who has been touched by the diagnosis of breast cancer. Many of us have a close family member, a loved one, a colleague, a friend, or a neighbor who's been affected by the diagnosis of breast cancer. Just recently, earlier this year, in February 2021, the World Health Organization announced that breast cancer has now overtaken lung cancer as the most commonly diagnosed cancer in the world among women. And that's been a change. It is estimated in Canada in 2021 that over 27,000 women will be diagnosed with breast cancer. 25% of all new cancer diagnoses will be breast cancer in our country. Every day, 75 women are estimated to be diagnosed with breast cancer. That's women receiving a diagnosis in their doctor's office, that they have a diagnosis that will change their life. 15 women every day, unfortunately, will die from breast cancer, an existing diagnosis, and 1% of breast cancer cases are found in men. In the province, because we want to talk about what affects us in Alberta, over 2,600 women are estimated to be diagnosed with breast cancer every year. This has actually been a fairly stable number for the past 8 years, and it is increasing in proportion of early stage breast cancer due to the increasing use of screening mammography. We have novel, innovative, rapidly changing treatments that are being developed and introduced around the world internationally every month, I would almost say, every 3 to 6 months. And I would like to say that I firmly believe that the cancer care we offer here in Alberta compares to world-leading centers around the world. And because a lot of these diagnoses are early-stage breast cancers or very small cancers picked up on imaging, not all women require a mastectomy. And to be honest, many women, when they receive that diagnosis from their doctor's office or from a phone call from their doctor, immediately one of their thoughts is, will I need a mastectomy? That leads me to talk about another option for women instead of mastectomy, and that is called breast-conserving surgery. Breast-conserving surgery is the removal of a small breast cancer that cannot be felt by the patient, first of all, or felt by the doctor on physical exam. So in essence, the woman is feeling well, she feels healthy, and then she goes for what is a routine mammogram, routine test, and then is called back later to find out something abnormal has been found. It's unexpected. Then they are offered many investigations thereafter, which ultimately culminates in a biopsy and information that tells them a very small area in the breast has cancer cells. So when we're talking about breast-conserving surgery, the goal, instead of doing a whole mastectomy, which seems aggressive for such a small thing, is to remove the cancer, the lump or tumor, with a cuff of normal tissue around it, such that all the cancer cells are removed. This can still lead to further treatment, but maximally treat the patient and not compromise on the overall outcome and cure the patient with further adjuvant treatment. And I'm a firm believer that by doing this and considering the overall cosmetic appearance and shape at the first initial surgery, would allow the woman to keep her breast and keep her female identity and keep the overall shape and contour of her normal anatomy. Because of these new treatments that I've been talking about, one of these that has really come to fore in the last 10 years and is increasingly used is specialized targeted chemotherapy. This sounds quite scary when I talk to some of the patients about it, and this is a very unique, individualized, special type of situation where a specific chemotherapy can target a specific type of pathology that bears certain tumor markers that are specific to the cancer the woman has. And by identifying those proteins, which are called receptors, a specific type of chemotherapy can be offered to the woman before surgery. And what this does effectively can shrink a large tumor to a much smaller tumor. Furthermore, if a woman has more advanced disease and has lymph nodes that are involved, the chemotherapy given before surgery can cause the lymph nodes to dissolve, in fact, and induce a response where we don't have to do as aggressive surgery in the armpit or the axilla. This is to say that if women have a good response to chemotherapy that is offered ahead of time, their disease can shrink so much that regarding the breast cancer, it will be so small that instead of having to need a mastectomy, which is what they might have needed in the first place, they could now have breast-conserving surgery, which is really amazing. So this all goes to say whether or not it was diagnosed as small or became small due to new treatment options, the small tumor must be identified for the surgeon at the time of surgery because we cannot feel it or see it. So we do need a method in which to find the actual small, tiny cancer in the breast at the time of surgery. And one of those ways, a complementary and well-known way, is to do an X-ray of the tissue after the tissue has been removed and confirm that the cancer area has been excised and that the marker that identified where the location of the tumor was is included. And here I'd like to talk about a very old method that has been around for over 50 years and really hasn't changed. It involved something called a wire or needle localization. It involves the insertion of a stainless steel hook wire that is sharp into the woman's breast the morning of the surgery, targeted towards the small tumor to mark where the tumor is in the breast prior to breast-conserving surgery. So here we have a picture of one of the X-rays taken after wire insertion, and these two funny clips. They're actually two different kinds of clips, as you can see, marking slightly different areas. The patient had to wake up very early in the morning to go to a radiology site to have this procedure. At the Peter Lougheed, for our patients in our community, they have to travel across the city. They have to go to another center that's not even in another hospital. It's not done at our hospital or any hospital in Calgary. It's done by special radiologists in a separate facility. Furthermore, the family members who are accompanying the patient and the patient herself are driving across the city, traversing the city multiple times, especially with the winter weather conditions coming up. I always worry about the situation. No matter how much I reassure the patients, they find the process stressful. They feel rushed because of certain times and appointments they must meet. And it's certainly a stressful day regardless, without the wire localization to begin with. The procedure can often be painful and uncomfortable. The wire is then taped to the skin of the breast so it won't be dislodged, which is also a concern for the patient. and it must be removed the same day as the surgery. This leads us to talk about the Faxitron that the Agate Foundation is so generously supporting. The Faxitron confirms the cancer in the tissue, and it's better than the image I just showed. So the Faxitron is a portable X-ray machine, and it provides a high-definition image, and it can be moved from operating room to operating room, and it's right there in the surgical suite. It provides a very quick X-ray assessment of the tissue. It identifies the cancer if there's an obvious mass. It identifies those little clips, and it identifies the wire to ensure that we know that we've excised enough tissue, as much as we can possibly know, before it gets sent to the lab and examined microscopically. So we can actually have an immediate, real-time assessment of how much tissue we've removed and if we need to remove more. So here's a picture of the device that's just taken off the website of the vendor. It's called a Faxitron Trident HD. As I mentioned, there's immediate feedback. The image is right on the screen. Clearly, this improves workflow. As I was discussing earlier, otherwise, the current system is placing the tissue on a grid, which is going in a box, and the box is taken by a porter to another floor in the hospital, and it goes to the radiology department where people come in for their x-rays and CT scans. And there is this little box with a little piece of tissue sitting on the counter waiting to be attended to. And I do a lot of phone calling to make sure that someone looks out for it, and the little box needs to get an x-ray, and then I do more phone calls to make sure that the little box goes to the lab where it ultimately needs to be. And then we wait for a radiologist to look at the images and call back up to the surgery suite to tell us if the image is all right. So if we had this available in the surgery immediately, we would definitely eliminate that long process. And all that time, the patient is still under general anesthesia. And so without needing that long process, the anesthetic time for the patient is shorter. There is a quicker recovery, and it would mean certainly that everything would flow so much better. It also incorporates the latest technology and software, and the radiologists would immediately have the images uploaded to their system, so the specialized breast radiologist would be able to read the image and provide an official report. I think this Faxitron also goes hand in hand with another new localization method that I have really wanted to advance in Calgary, and particularly for the community at the Peter Lougheed. There's interest across the province for something like this. It's called the Magseed, or the Centimag system, the two together. What it consists of is a small magnetic seed, and it's no larger than a small grain of rice. And this tiny seed can be inserted into the middle of a small tumor, which is only 1 centimeter or smaller, and it can be performed as an outpatient procedure days before the surgery, a week before the surgery, a month before the surgery, and very recent data suggests even months, multiple months before. And that would be so relevant for our patients having that new treatment of the pre-surgery chemotherapy. The little seed is inserted in a quick procedure, and patients have found it very convenient to go separately on a different day from their surgery. There is no rush. They find it separated and very much less stressful. And it's not as painful. And that may be because it's just not as stressful for cramming into one day. It's very accurate. The seed sits inside the center of a solid tumor and does not migrate or move. And then in the surgery, we have the system which localizes the seed in the breast tissue. That's called the Centimag. This is actually a fancy, refined metal detector. And I like to think of it as a very similar machine to a character in a movie who's walking along the beach with their metal detector, scanning the sand, beep, 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 and looking for that Seiko watch, that undiscovered treasure. And it's very similar in that the probe device is the size of a Sharpie marker, and as it gets closer and closer to the Magseed, it makes a higher signal and sound. And what is even more special about it is that the reading from it will approximate quite accurately the distance from the tip of the probe to the seed and therefore the tumor, which we don't have that kind of feedback with a wire. So the advantages of the Faxitron Magseed coupling of the two technologies are immense. I think it's so important for our patients that we could employ this in Calgary and potentially further. This would allow to have smaller volumes of breast tissue removed with lumpectomies, only what's needed, not what's not needed. And this would allow still better outcomes because we don't need to remove extra tissue to get a cure or to have the best outcome. In addition, I am very passionate about, from the very get-go, that women get the best surgery from the very beginning. And by doing this type of highly technological approach, we can improve patient cosmesis. We can allow for more of the woman's natural breast to stay, maintain the normal contour and the shape, and ultimately, over time, the breast cancer diagnosis for early stage breast cancer will be something of the past. And the satisfaction long-term for survivorship is so important. I want years down the road when women are getting dressed, going to a fancy event, that they have totally forgotten that they ever had breast cancer, and there's no daily reminder when they get changed or go out. So these two systems provide us real-time results. They're accurate and safe. These systems are widely used right now in Europe and multiple centers in North America. It allows for efficient scheduling on multiple levels, less delays at many levels, and also we can consider that it would offer less repeat surgeries in the situation where the cancer is not totally removed, because we would have a better margin assessment during the surgery. And there's no statistic that can measure less stress for the patient and their families, but I think this whole experience could be much less stressful for our patients. This picture speaks for itself, I think. This is a low definition image, and you can see the little lighted rod in the center is a Magseed, and it's in the center of this 2D image, and it is perfectly marking a tumor that has a very nice, even cuff of tissue all the way around. And that's why I'm so grateful for the incredible donation of the Faxitron and Magseed Centimag system by the Agate Foundation and the Rance and Marilyn Fisher Family Foundation. Thank you to Mr. John DeSanti and Mr. Rance Fisher for your kind support and amazing generosity. A big thank you to my colleague, Dr. Arash Vard, for his support that began years ago. And a big thank you, of course, to my colleagues for their unwavering support at the Department of Surgery at the Peter Lougheed Center. Thank you to my exemplary colleagues at the Tom Baker Cancer Center, whom I so much value their multidisciplinary care and support of our breast cancer patients. Thank you so much. Thank you for listening.